My name's Katherine Howell. I won't introduce myself again because Ingrid just did. But I'm going to be covering a lot of different things over time. I'll probably speak for about 25 minutes and then I have questions. But if you've got burning questions along the way, this is fairly informal, so you can ask them. There are some conditions I'll have time to cover and some that I won't, but they can be part of questions if yours is one that I haven't addressed. So just to put things in a little bit of context, genetic epilepsies can be due to changes in one gene or changes in a number of genes, and where you get changes in a number of genes, what we're usually talking about is a chromosomal abnormality, so a missing or extra bit of a number of adjacent genes. Some of your children will have conditions will have chromosomal abnormalities. So I'll come back and talk about them a little bit later. A lot of the stuff I'm doing early on is about single gene disorders. We know that there's more than 300 different genes that have been associated with seizure disorders, some of them for which epilepsy is the main feature, and some for which it's part of it but not the most difficult problem. As far as all epileptic encephalopathies go, no one gene is thought to account for more than 1 to 2% of all of these. And obviously that makes the whole landscape of this very complicated. When you start to drill down on different types of epilepsy though, those numbers change, and there are some epilepsy syndromes for which there are relatively common genes. So Ingrid's talked about this a bit briefly. This is just to highlight a little bit about how complex things are. So this is a picture of a neuron, so a nerve cell. Here's one, here's the adjacent one. And all of these proteins highlighted are really just showing that an abnormality in almost any aspect of neuronal function can cause epilepsy. And does this by changing how excitable the cells are and how they communicate with each other. There are a couple of groups of conditions that are more common, including those that are abnormalities of the ion channels or the salt channels, and those that disrupt synaptic transmission, which is how one cell communicates with the next cell. So the mutations in these genes affect the function of the protein that is coded for by the gene. So the genes like the recipe that makes the protein is what works in the cell. But the impact of the mutation really depends on exactly what that particular protein does, how the mutation disrupts it, and when in life that protein is actually required. For example, there are some conditions where the protein is required from the newborn period and symptoms will present from then, and others where you don't actually really need that protein all that much until later in life, and that can sometimes mean that things don't present until a bit later on. That's not an all or nothing thing, but there are a few conditions where that actually does hold true. So until not too long ago, we didn't have a lot of access to genetic testing, and we didn't really have techniques that looked at more than one gene at once. And we were heavily reliant on our clinical skills, and I think we still are and should be, but things have changed a little bit. And so I think with the advent of understanding the genes, we also now understand the conditions better, because you can look at larger groups of children with the same disorder and understand the things that are similar and different. And we probably now can better predict which genes are more likely based on both knowing what the genes are but also knowing what the clinical picture is. And that really has some implications for a treatment, sometimes even predating making a diagnosis, a genetic diagnosis. Sorry, I'll just, that's sort of covered all of that. So where we're at the moment is a pretty complicated landscape where what we often come up with when your child presents with seizures is an understanding of what the seizure type is, what the epilepsy syndrome is, and that's the combination of seizure types and EEG features, and then what the other features are. What is the developmental profile of the child, which additional clinical features, whether they're neurologic things or non-neurologic things like problems in other organs. We now sort of have a little bit of a schema about which genes we know go with different epilepsy syndromes. And as you can see, it's really quite complicated. For some epilepsy syndromes, there are a few genes, and for some there are a lot, and this is by no means an exhaustive list. But this is just to give you a little bit of an idea of the complexity of things, and I'm obviously not going to cover all of these genes today. Without further ado, moving on to some of the particular genes. So SCN2A is one of the sodium channel genes. That's one of the ion channels, the salt channel genes that is on the membrane, the outside of the cell, and helps get salts across the membrane, and that is one of the major determinants of how excitable a cell is. This is one of the more common infant, neonatal and early infantile epileptic encephalopathies, and as Ingrid mentioned before, it's one of the genes with a real range of fairly benign seizure disorders through to very severe. There's over 200 patients now reported with severe epilepsies, and this is probably one of the conditions we understand better amongst the epileptic encephalopathies. Amongst those with severe epilepsies, there's two distinct groups. The one we appreciated earlier and for which there are more patients described is a group where there's a neonatal onset of seizures, and another increasingly recognised group is that those that don't start having seizures until mid-infancy, and the seizure type is different. So just to expand on that a little bit further, so those with the early onset seizure phenotype present with seizures at less than 3 months, most commonly actually in the first week of life, so seizures are actually usually the first thing noted. They're most commonly focal seizures, so seizures just arising from one part of the brain, but most children actually have lots of different types of focal seizures, so you might have a seizure coming from here, then one from here, then one from here. There are different epilepsy syndromes. It's one of the more common causes of Ohtahara syndrome and epilepsy of infancy with migrating focal seizures, and some children are not classifiable with a named epilepsy syndrome. Unfortunately, this is a condition that is very resistant to most treatments, but what we're now increasingly recognising is that some children will respond, and some respond very well, to drugs that block the sodium channel, and particularly phenytoin. Now, phenytoin is, some of you may have had your child use phenytoin. It's traditionally not our favoured epilepsy drug for various reasons, including that it's very difficult to use in babies because of the ways they metabolise it. But we're now increasingly using it, and for some children this makes the difference between being stuck in hospital having seizures every few minutes and actually having periods of seizure freedom. Some of the other sodium channel blockers that I've listed up here help, but none of them seem to be anywhere near as effective as phenytoin, and we don't really understand why that is at the moment. Unfortunately, despite the fact that we can make a major difference in seizures with some kids, the becoming seizure-free on phenytoin really doesn't seem to improve development, unfortunately. So we've got a fair way to go to try and improve that aspect of things, and obviously that is really the major issue once you can control seizures. I should say that not all children with this do respond well to phenytoin. It's not clear whether some might not have had an adequate trial of it, because sometimes you actually require a really high level of phenytoin in order to have seizure freedom, and that may not have been achieved. The other thing is sometimes there's a little bit of a trade-off between seizure control and developing some other abnormal movements, and it's a little bit of a balance sometimes between what's the lesser of two evils, I guess. So most children with SCN2A encephalopathy have developmental delays, and they're usually quite severe, but I suspect we probably don't understand and appreciate the milder end of the spectrum as well as we should, and that's actually the case probably with a lot of the epileptic encephalopathies, because until recently, when we've had much better access to genetic testing, most children who received a diagnosis received it through research avenues, and it tended to be the children with more severe conditions who actually were involved in research. So it's only really now we're starting to diagnose more of the children who have a less severe condition, and so that there may be a relatively milder end of the spectrum with children with mild to moderate developmental delays. Movement disorders are really very common. They can be quite problematic or they can be mild, but sometimes they're a major feature. And as I mentioned, sometimes the anticonvulsants used can actually impact on how problematic that is. Often children are quite floppy in their trunk and neck, and they may or may not be stiff in their arms and legs. And gastrointestinal issues are really very, very common, and they can be really problematic, like really bad constipation or reflux. And so that's something that we often spend quite a bit of time trying to address and can be very tricky. The later onset group is still an infant seizure disorder, but seizures don't start until mid-infancy, usually in sort of 6-ish months age group, when children present usually with infantile spasms and sometimes with tonic seizures. Now that's not the first manifestation here. Usually children have had other problems noticed beforehand, and some of these children actually spend quite a bit of time in hospital because vomiting, weight loss, failure to thrive, and the need for supplemental feeding actually is quite a prominent problem in some of these children. And they may have a movement disorder that predates the seizures as well. Once the seizures crop up, they tend to be difficult to control. They're resistant to most treatments, and in contrast to the early onset group, sometimes these children are worse on sodium channel blockers, and we think that's because of the different types of mutations that cause these different things. The very early onset group probably has an overactive sodium channel, and this group an underactive, so if you block it further, you cause more problems. Seizures might change in type over time. We do notice that some children's seizures improve after about the age of 4 years. Don't really know why that is. Oftentimes after that age, the movement disorder is the most prominent thing. Intellectual disabilities, developmental delays are prominent, often not quite as severe as with the neonatal type, and behaviour and irritability can be very significant issues here. And unfortunately, I don't have a good answer for that yet. That's often a thing that really impacts on families' lives. The potassium channel gene KCNQ2 is another ion channel, but this time potassium, not sodium. And it and SCN2A are really the two main causes of neonatal and very early infantile focal seizures with a normal MRI. In fact, for those type of disorders, they probably make up more than half of things. And as I'm going to mention, they also respond to sodium channel blockers, and really this has changed our practice in how we deal with neonatal seizures, in that we would use these drugs a lot earlier than we previously would have, and sometimes with these children we can gain seizure control before we've even got a diagnosis, which historically really didn't happen. So again, a range of severity, and again within the severe group there are two distinct groups with very, very similar features within the groups to what SCN2A looks like. The mid-infancy seizure onset group here, really, there's only a few cases reported, so I won't actually talk about that in detail. A lot of this here mirrors what I've said about SCN2A, so I won't repeat that, but I will highlight the differences. One of the differences is this condition seems to respond a bit better to other sodium channel blockers, so I don't mean better than phenytoin, I mean it also responds to other ones. And so sometimes it's actually preferential to have children on one of the other sodium channel blockers because they're better tolerated and easier to maintain a stable level. So where you would usually, if we didn't in the first place, transition them across to something other than phenytoin. In contrast to SCN2A, the seizure tendency tends to settle with time. In SCN2A, if you're not on phenytoin or something that's controlling your seizures, you will generally keep fitting into childhood. Whereas these tend to settle with time, and after about 3 or 4, many children don't have seizures or only have rare seizures. So that means that some children with KCNQ2 can come off medications, and it's also quite important because there are children with KCNQ2 who have other types of movement disorders too, which are often difficult to differentiate from seizures. And so the knowledge that a lot of the older children don't have seizures should raise the suspicion that maybe the things they're having are actually not seizures. Sometimes you need to prove that one way or the other, but it's important because seizure medicines won't help and other things might. So the things that are quite common that are not seizures are non-epileptic myoclonus, so you can have myoclonic seizures, but you can also have myoclonus jerky movements like that. that are not actually seizures as well. And some of those children having those jerks are thought to have infantile spasms, but actually infantile spasms are really quite uncommon in KCNQ2. They're a bit more common in SCN2A. These children sometimes have a transient abnormality on their MRI scan in infancy. If you get scanned in the first couple of months of life, sometimes you see a change in the basal ganglia, some of the deeper bits of the brain. That then goes away and the scans often look normal later in life. It can be a diagnostic clue early in infancy, but it's a bit non-specific. Ingrid showed a nice video of a child who was quite severely affected with KCNQ2 with very severe developmental outcome and a movement disorder. There actually is a reasonably sort of broad spectrum of severity of developmental outcomes, but a lot of children would have at least a moderate level of intellectual disability. Again, we may not quite appreciate the milder end of the spectrum as fully as actually is there. The next one is SCN8A, and this really completes the trio of things that are very sodium channel responsive, sodium channel blocker responsive in terms of medications. This again is an ion channel gene, again a sodium channel one, and it presents a little bit later. Seizures start in mid-infancy, and the presumed explanation for that is the on your excitatory neuron. So you've got different types of brain cells, ones that are excitatory and ones that are inhibitory, and they have effects of promoting electrical activity or dampening it down. On the excitatory brain cells, the main sodium channel early in life is SCN2A, and that gets replaced by SCN8A at about 6-ish months of life. And so because you don't really need it earlier on, you don't tend to have seizures until you really start to need that and you don't have it there. So it probably explains the later age of onset. Again, there's a range of seizure severity, but a very, very benign end of the spectrum really hasn't been appreciated. So the epilepsy typically starts at about 5 months, but there's a broader range. There are a lot of similarities clinically with SCN2A, but in evolution there's sort of often multiple other types of seizures other than focal seizures that arise. Again, response to phenytoin and oxcarbazepine is noted. Prior to seizures, the child may or may not have had other problems. You can have had completely normal development with no medical problems, or you sometimes may have a mild developmental delay. Often there's a developmental regression at the time that seizures start, and most children end up with a moderate to severe developmental delay. One of the things that can be really prominent and problematic is the movement disorders, and so non-epileptic abnormal movements and things like dystonia, so twisting postures, and non-epileptic myoclonus and excess startle are very prominent. In some children that predates the seizures, sometimes even from the newborn period, and there are some children with SCN8A who were thought to have seizures in the newborn period, investigated for them, proven not to be, who subsequently do have seizures, and that was their non-epileptic movement disorder. Some of them, they look for all the world like seizures, and it's no surprise that children get investigated for seizures, and very appropriately, but they can be very prominent and very jerky movements. Other intermittent neurological symptoms like dysfunction of the, we call autonomic function, so breathing, heart rate, things like that can happen. Some of these children have very prominent intermittent rapid breathing. Often these children are very, very floppy, and there's some suggestion that may actually be a nerve disorder as part of this too, but that's not really, I don't think that's really proven, but these children can be quite a lot more floppy. Sometimes limbs are stiff though. Some children with this condition do walk and are quite unsteady with their walking. And the other thing to say is that this can be a difficult diagnosis to make clinically, and we're now appreciating things better. Many children will have a normal MRI brain scan, but a proportion actually have a very prominent abnormality that changes over time and is often mistaken for a metabolic disorder or a mitochondrial disorder because of the patterns of changes. So I guess, I don't know if there's anyone with SCN8A in the audience, but that is certainly something that we know can happen. KCNT1, another potassium channel gene. Ingrid mentioned this because that was the condition in which quinidine was used and was the great hope, and unfortunately hasn't quite panned out in the way that would have been lovely to see. But this is a gene that is associated with disorders with focal seizures of a couple of different types, both severe conditions, but severe and extremely severe. Just to briefly go through this, this is the first gene known for a condition called, well, first major gene for a condition called epilepsy of infancy with migrating focal seizures. So it's a very onset in the first few months of life of multiple types of focal seizures where you just basically see a seizure from here, a seizure from here, a seizure from here, just migrating from one side of the brain to the other. It's thought that it probably accounts for about half of cases of EIMFS, which is the abbreviation for that. In these children, we haven't hit on a medication that really works for them, unfortunately. Seizures tend to continue over time. They continue as focal seizures. It's very uncommon to have infantile spasms or other seizure types with this. But even though seizures continue, they can become less problematic with time, and we tend to see children don't spend as much time in hospital after infancy as they can do early in life. Development can be normal prior to seizures, but you tend to have developmental delays and intellectual disabilities later on. Movement disorders really aren't very prominent here, but a lot of children will have abnormalities of their tone with floppiness or stiffness, and sometimes the heads become small over time. The later onset form is a little bit less severe. It's called autosomal dominant nocturnal frontal lobe epilepsy, and which basically just means you have seizures coming from the frontal lobe at night, as the name implies. And so these seizures are often very difficult to control again. In contrast to other types of autosomal dominant nocturnal frontal lobe epilepsy, intellectual disability may occur, but it can be is often milder, well, it's typically milder than in the EIMFS cases, but can still be quite significant. It's called autosomal dominant because we know that you need one faulty copy of a gene to have it, but you can also pass it down through generation. Some people with this condition actually do have children and may have normal intellect or only mildly impaired, and actually can have a job and care for a family and things like that. That's not the case for some others. Psychiatric disorders can be a feature of this too, and can be something that is one of the more problematic aspects of life. I think the last individual gene I'm going to talk about is PCDH19. And this is a gene associated with a condition that has a number of different names. Epilepsy and mental retardation limited to females, girls cluster epilepsy, and a Dravet-like epilepsy, because it shares some clinical features with Dravet syndrome, although also has some important differences. Ingrid's mentioned Dravet syndrome a few times today as the condition associated with SCN1A mutations, and there is some overlap. So the PCDH19 gene encodes for a protein that actually has a lot of different functions in the cell. It's a molecule that helps one cell adhere, join to the adjacent cells, and that actually has multiple functions. It's an X-linked condition, so the gene is on the X chromosome. It mostly affects girls, which is a bit different to a lot of X-linked conditions, which tend to be more severe in boys. And there's the reason that we think that happens is that you seem to need a population of faulty cells and a population of normal cells in order for the condition to come about. So if you are a girl without the mutation, you have 2 X chromosomes, you have 2 normal populations of cells, you don't have a condition. If you are a male with the mutation, you have 1 X chromosome, 1 Y chromosome. Your X chromosome produces a faulty population of cells, but you still only have 1 population of cells, and that's okay, you can get by with that. If you're a girl with 1 normal copy and 1 faulty copy, you produce a population of cells that's faulty and 1 that's normal. When you've got that mix of things, that's what causes the problem. And so that's actually quite an uncommon pattern of how a condition is produced. So there's now quite a number of cases reported in the literature. I couldn't quite tell you how many, but there are a lot, and the epilepsy is actually very well described because seizures are obviously one of the major and early issues of this condition, and so affected children are very closely followed by neurologists and epileptologists. So seizures tend to start between 4 months and 3 years, but most commonly at about 9 months of age, and that's the first thing that differentiates it from Dravet syndrome because that's a few months later than Dravet usually starts. You can have seizures with fever, febrile seizures, and afebrile seizures without fever as well. Seizures typically happen in clusters, and so that means numerous seizures within a space of time. That may be a day, a few days, or even sometimes weeks. And that may sort of meet the definition of status epilepticus, but they do tend to be discrete seizures, but often one rolling into the next. So there is quite a characteristic seizure, the clinical features of the seizures. They tend to be focal seizures, and one of the most common descriptions of the first thing is a description of fearful screaming or some other kind of emotional type initial presentation. It might be a jerk and a sort of change to the face. It may actually be a scream like someone's afraid. It then evolves to have numerous other stages to it, which are variably described. If you read about it, you'll see different descriptions, but there tends to be a little bit of stiffness, sometimes some fluttery type movements, and sometimes some clonic type movements, but the description of the tonic and then the clonic type movements is that they're not as pronounced movements as what you would typically have in your head as a tonic-clonic seizure. The seizures, over time, seizure clusters in some children continue, in some they stop completely, and in some where they continue, they are a bit less problematic and a little bit further apart in terms of how often clusters are seen. There are lots of different medications tried. There's a paper reporting which seem to be of most benefit with, hang on a sec. Sorry about that. With no real favourites, but it seemed like clobazam and frisium, steroids and phenytoin work in some children and improve things. Interestingly, bromide was said to be one of the more effective medications. I'm not sure if you saw the slide that Deepak put up about when drugs came on board. Bromide was developed in about the 1850, I think. It's about the oldest anti-epileptic medication, and it is extremely rarely used now. I can think of one patient I know of that we've put on bromides, and really, it would be beyond your 10th choice. So whether or not it actually was effective here, I don't think we can really answer, because what we do know with the natural history is sometimes things improve over time, and if it happens to be the 10th or 12th medication you're on and it's the one that's tried at the time you were improving anyway, I suspect that that's probably not a true thing. So the steroid aspect of things is interesting because it's been shown that children with PCDH19 mutations have reduced levels of some steroids in their body. So steroids are a whole family of different chemicals that act on the nucleus, the centre of the cell, to have various functions there. Lots of different types of steroids. You're probably familiar with anabolic steroids that athletes used. Some of your children might have had corticosteroids like prednisolone or ACTH. And there seems to be a different type of steroid again that kids with PCDH19 are deficient in. There are some studies going on about whether those kind of synthetic versions of those steroids might actually be beneficial, and they're ongoing. Development-wise, most children with PCDH19 have normal development or very mild delay prior to seizures. Regression can occur with seizure clusters, can be quite prominent, can be problematic. There's a range of developmental outcomes, including some children who have normal development. And autistic features may be present, but are not in all children. Sometimes children have some unsteady walking. Other sort of motor features or non-neurologic features are not particularly common, but things like sleep and behavioural problems can sometimes occur, as they can in most epileptic encephalopathies. So lastly, condition-wise, just to come back to copy number variants. So I won't actually go on about what they are because Ingrid talked about that, but with copy number variants we actually knew about before a lot of the single gene conditions, because chromosomal testing is actually something we've had for a lot longer, and we've had better access to it clinically as well. So a lot of the epilepsy genes were actually found by looking at the copy number variants and saying, okay, well within this one we know the children with this one have seizures, and within this one which genes look like they could be a candidate for a seizure disorder, and then going back to a population of children without a diagnosis and sequencing particular genes in that. In that fashion, that's actually the way a lot of epilepsy genes were discovered. So within the number of genes missing, you might have one or more that's responsible for the epilepsy. There are often other features as well, including non-neurologic features sometimes, so there can be abnormalities of other organs or unusual facial appearances. They're often due to other genes other than the epilepsy ones. And sometimes there are quite characteristic features, and a diagnosis can be made prior to seizures arising, sometimes if the doctor is familiar with the clinical features. A lot of as Ingrid mentioned, a lot of the significance of the copy number variants is difficult sometimes, but there are some very well-established copy number variants which are generally considered to be pathogenic, although with variable severity, in which epilepsy is a major feature. I've just listed a couple of them here. There are quite a lot more. And in these particular ones, the epilepsy is reasonably well described. It's actually not the case for a lot of other copy number variants, because how well described something is really depends on who's studying it and who's reporting on it. A lot of the copy number variants, the papers in the literature, are written by geneticists who are not experts in epilepsy. And so if your child has a condition where we don't have that information, it can be actually kind of difficult sometimes to manage the epilepsy, because we don't have a lot of guidance as to what has worked for other children. We certainly have very standard approaches of how to deal with that, which depend on the type of seizures and the epilepsy syndrome. But some of the nuances of things that we see with the single gene things, or the better described ones, are missing for some of the copy number variants. So I can, I might just leave that bit there and just to put up a list of things that I know I probably missed some, but these might be useful to you guys. Some of them you may well be heavily involved with already, and I've probably missed some, and feel free to let me know if there's one you know about or are involved in. Most of them actually also have Facebook groups. Some of them I'm not aware of websites, just Facebook groups. So hopefully that's helpful to some of you. I'm going to take questions now. I'll leave that up. So go for it.
My daughter has PCH19, and there's obviously, given that she has cluster seizures, and it's all very dramatic, there's a lot of hands on deck when you're trying to manage her seizures when they rear. But we as a parents equally struggle with some of her behavioural issues, especially in clusters.
Yep.
I shouldn't say the word, but we have to restrain her. She's just beside herself. Nobody's approached us yet about medications that can perhaps take that edge off, especially around seizure activity. Is there anything that I can ask for help with regarding that?
Yeah, so that actually is a very difficult thing, and both in a day-to-day point of view and during seizure exacerbations is something that's often extremely difficult for people. I think you generally need to take them as two slightly different things, the behavioural problems that are kind of there all the time, and the things that come up around the time when seizures are really bad. Probably the best thing for behaviour when seizures are bad is actually to stop the seizures. Because behaviour is probably worse because of the abnormal electrical activity that's going on at the time, either because there's a seizure there or because of how the brainwaves are deranged in between seizures coming and going. So that would certainly always be my first approach. Sometimes people hit on things that work for them, but one of the difficulties is that if you're not treating the underlying cause of the problems, you're sometimes just things that other medications for behaviour or things like that are often less effective and may sort of add to side effects and things like that. So I think seizure control is probably the first thing, but also looking at behaviour and stuff, at behaviour and sleep at other times and seeing what works at other times, and sometimes you can make modifications to those things during seizures. Sometimes maybe you need a bit more of something that you would be using. All of those things really have components of non-drug management and drug management. By non-drug things, I mean sort of behavioural strategies, things to sometimes kids who are really agitated in the context of seizures, sometimes things like minimising stimulation along the lines of what people recommend for people with dementia and things like that, the older people who get really agitated in the evenings, that kind of thing, low stimulation kind of environments, not a lot of light, not a lot of noise. Those kind of things, things that are familiar, comfortable for them, parent their favourite toys, those kind of, I guess, basic things that we would always try. And then medications as well. And often the medications that help in the broader everyday context are probably more likely to help then, but really it's because the seizures are worse.
Yeah, I don't think we're quite talking on the same level here, because I'm not talking about behaviours that can even be managed by environmental aspects. For example, she's out of control.
Yeah.
She's out of control. So is there any, and all her medicines she has adverse reactions to. She also has chronic insomnia.
Yep.
And they can't knock her out to sleep at all. So is there anything that you can think of that can just take the edge off her? She's just beside herself. We're beside ourselves. Days without sleep. It's awful.
Yeah, no, it is really awful. I think at the extreme levels, you really are largely talking about drug management of things, because you usually have implemented all of the things that work for less severe things, and those things should still be implemented because they can help, but you usually need more. Again, it really depends on what the role of seizures is. Again, if it's in a cluster, treating the seizure is probably going to be the best thing. Talking to a sleep physician like Margot is probably going to be helpful for you, because insomnia can be a real problem. Sometimes kids who are prone to insomnia can sometimes have the opposite reaction to some of the medications. To other children, medications that might sedate some children actually hype other children up. And sometimes it's knowing what to avoid as well as what to have. So I think having a discussion about which medicines they're on, what the context is in which the insomnia is occurring, and talking with a sleep physician are probably worthwhile things to do.
We have a few questions that have come through.
Oh, sure.
Okay, and maybe you can repeat it just so
Yeah, of course.
So one was about information around boys affected by PCH19.
Yep.
Much less common. But
It is, yes. So the question was about boys affected with PCDH19. I actually didn't mention that situation, but yes, that can occur. It's uncommon. And it occurs when you've got, we call a mosaic mutation. So boys usually just have, they have one X chromosome in almost all circumstances. If you happen to have more and a Y chromosome, or if you have a mutation in some but not all of your copies of your X chromosome, then in a boy you can still have a population of normal and abnormal cells. So in those rare circumstances where that occurs, you can have a boy who is affected. A lot of the clinical features are really quite similar. For example, the epilepsy type of seizures and the fact they occur in clusters where that's reported, it looks to be quite similar. Again, there can be sort of variable severity within the boys affected, but really there's only a handful of cases in the medical literature. I'm sure people involved in PCDH19 groups are probably aware of more people, because not everybody's child is the subject of a publication. I'm not sure who was next. Sorry, you've been waiting for a while, I think.
My son has 2Q23.1.
Yep.
And so in hindsight was having seizures from birth. Kind of wasn't picked up till about 2.5 years, and then diagnosed with that at 3.5.
Yep.
Severe epilepsy, and then he's nearly 13, and we've been seizure-free now for about 4 years.
Fantastic.
So, which is noticeable seizures, I should say.
Sure.
I'm still holding my breath.
Yep.
So the question is, obviously the genes are still defective.
Yep.
So what kind of makes, we've obviously tried heaps of medications, found the one that's the good. Is
Yep.
it because he's matured? Is it, do you know what I mean, the likelihood of it coming back?
Likelihood of coming back, yeah. So it's the $1 million question, isn't it? It's the thing that you're holding your breath waiting for, and hopefully it will never happen. The epilepsy in 2Q23.1 is probably less well described than in a lot of other conditions, and so where that's the case, it's a little bit hard to know at a sort of population level what the likelihood is there. So we tend to be going on case reports and things, but also based on what we know about seizures and epilepsy. And really, I think any child who's had a difficult to control epilepsy may later on also have a difficult to control epilepsy, but that's not necessarily the case. We also know that you can have a difficult to control epilepsy that then goes away completely, or that becomes treatment responsive. So there's sort of 3 things that could happen. One is that seizures could come back. 4 things. Two of them are seizures come back, difficult to control, not so difficult to control. 2 is that seizures don't happen, but you either need to stay on medications or you could come off them. What we tend to try is, if you've had a period of seizure freedom, we often get to the point where we say, look, could we actually start to come off medication? And really that's a totally reasonable thing, often something that people are very worried to do. But generally we would, if you've been seizure free for a while, we would generally do it one medicine at a time and quite slowly. Tailor it to the situation. Obviously it's the kind of thing that sometimes we'd say, okay, well, do it during school holidays, or do it when you don't have something really important coming up and where you've got a less stressful period of life, I guess, to do things in. But that's, I guess, where things would go from here.
Why don't they stop? Do you know what I mean? Like the gene is still defective. So I suppose what I'm asking is, you've still got a defective gene.
Yes. So it depends a little bit on the way the brain works at particular ages and what you need particular genes for. So, for example, in the KCNQ2 one I was talking about, so there are some conditions where we know that happens. Sometimes we get a bit of an idea based on when we know the gene is necessary. Other times we don't know that and we actually have no idea. We just know it happens. Yeah.
I was just wondering if you had any more information on the FLNA gene.
The filament A gene?
Yeah.
Yep. So,
Website.
Oh, I don't. I can find out for you, but I don't. So, do you want me to?
Is it XQ2A duplication that you? Because my son has a duplication, including the FLNA.
Yeah. So you can have that in the context of a copy number variant, a duplication or deletion, and you can have mutations within the gene itself.
Yes.
In the gene itself.
Yeah. So. Filament A is something that, again, is X-linked, and it presents differently in girls and boys. Its probably most well-known association is with something called periventricular nodular heterotopia, which basically is a malformation of the brain where collections of nerve cells actually aren't out on the surface of the brain, they're deeper down. And that can cause seizures. We also know that intellectual disability can be a feature of things, but not always. Again, the likelihood of having seizures and severity of seizures is quite variable within that. Yeah. One of you two?
I don't have a question, so I'll be quick. Just another website if anyone has SCN8A.
Yeah.
It's www.thecute.
Oh, Cute Foundation. Cute Syndrome? Cute Foundation.
Cute Syndrome.
Cute syndrome. So that was www.cutesyndrome.com.
Yeah.
Excellent, thank you.
Any knowledge about 1p36 duplication that you can share?
Not off the top of my head. 1p36 is an area of the chromosome that is highly important for brain function, and you can have abnormalities of brain function whether it's deleted or duplicated. You can also have abnormalities of brain structure. And epilepsy is a very well recognised thing. Off the top of my head, I can't tell you more about the duplication thing, but I can find out for you if you like.
Do you know of many patients affected with that?
I personally know of more patients with deletion than duplication, but there are reported patients with the duplication. Yep.
My son has XQ28 duplication.
Yep.
With Rett syndrome is like a deletion of the XQ28, and duplication often is called MECP2 duplication.
Yep.
He doesn't have a duplication in the MECP2, so
Yep.
he's even more rare.
Yep.
There's recently there's research going on to look into these disorders, and specific treatments for them. But because my son sits outside of the MECP2 protein, I'm just wondering where I could go. So many of his symptoms and epilepsy follows in the MECP2 duplication, but it's like they're researching a specific protein
Yep. Yep.
to help out. But how's that going to help my son?
Sure.
You know what I mean?
Yeah. Yep.
When
So
he shows such similar.
yeah. So I think that's a tricky thing, because across all sorts of different types of epilepsy, whether they're close by on chromosomes or totally different, there are a lot of very similar features. And so we can learn some things from some conditions and extrapolate them to others. But what you find for one particular condition doesn't necessarily mean that will help others. Now, on XQ28, there are a couple of different recognised duplications very close to each other. And then some people have different ones again that are sort of overlap things. So there is a recognised one adjacent to the MECP2 duplication that doesn't include MECP2. I'm not sure if that's the one your child has or whether they have something that overlaps a little bit.
Have the FLN.
Yeah, so I can't tell you for sure which bits are where. So what I'm getting at is the MECP2 stuff probably won't directly help your child if they're looking at things that directly impact on MECP2 protein. But if they've got, if your child has the adjacent recurrent duplication, there may be other people out there who, I don't know whether there's any research being done, but there may be some other people out there with kids with the same condition, and obviously sharing information can help. But it's very hard when you've got something where it's rare and there's not a lot of stuff going on. We do what we can to take information from other conditions, other things that work like that. Not just because you don't have the same genes doesn't necessarily mean other things that we learn from other conditions mightn't help, because if you've got something that has a very similar mechanism of action, a similar type of protein, something within the same family of proteins, sometimes you can get information from other things. To answer your question better, I'd probably need to know exactly what it was and the genes in the area. Yeah.
Just one more question. As a general information, generally we know that there are a lot of genes that are defective that can cause epilepsy. There's a lot of advances that are being made in gene therapy.
Yep.
Is there any disorder that is close to being targeted with gene therapy which will result in improvement in that?
Within epilepsy, there's a number of conditions where things are being developed and are currently being tested in animal models, and there are some things that we have some preliminary results in animal models. Nothing has moved yet to humans. The techniques they're using, there are some trials in other conditions where those techniques have been used, and that's important because we sort of at least know that those techniques can be performed and have been